Hello, ladies and gentlemen. Welcome to Triple N Media COVID-19 World News. I am Dr. Nik Nikam from Houston, Texas. Today we are going to focus on long COVID lung syndrome. Many patients who have had pulmonary involvement during an acute phase who were in the intensive care unit continue to have lingering symptoms of shortness of breath, fatigue, and many other symptoms, along with persistent changes in their pulmonary structure. These patients have reduced work capacity, and they also may have reduced prognosis over a long period of time, which has to be determined. But let us look at the pathogenesis of what is happening in the lungs and why these patients are getting chronic lingering symptoms long after they had recovered from the acute bout of COVID-19 infection. Before we proceed any further, I just want you to let you know my book on COVID-19 pandemic is available on Amazon.com. Please take a look at that and leave your comments on Amazon.com. Thank you so much for your support. So let us begin with the feature presentation. With 53 million people all across the globe having COVID-19 infection, with 1.3 million deaths, and here in the United States, almost 11 million people who have COVID-19 infection, with 248,000 deaths. There are a lot of people who are left with long-standing, lingering symptoms of shortness of breath, cough, fatigue. So this has been termed the long COVID syndrome. I would like to give a more descriptive term as long COVID-19 lung syndrome. This is seen in patients having debilitating symptoms for months. There is evidence of a permanent damage to the lung parenchyma and also the capillary system. Similar changes may be happening in other organs such as liver, kidneys, heart, brain. Let's look at the pathogenesis of COVID-19 or the coronavirus infection. The coronavirus gets into the upper respiratory tract through the nasal passages, and then it traverses into the bronchial tree and reaches the alveolar level. At the alveolar level, these coronaviruses enter the alveolar epithelial cells through the ACE2 receptors using the spike protein that is seen on the surface of the coronavirus. With that, there is replication of the virus inside the epithelial cells, and then the destruction begins to happen. There's more viruses produced along the process. The epithelial cells are damaged and they are replaced along with accumulation of protein-rich fluid known as hyaline fluid, which fills the airways, which interferes with the exchange of oxygen and carbon dioxide. On the arterial side, when the capillaries are lining these alveolar cells, they also have endothelial cells which have the ACE2 receptors, and these endothelial cells undergo a similar destruction as we see in the epithelial cells. The damage to the endothelial cells, on the other hand, releases tissue factors which leads to coagulation, leading to thrombosis, and thus reducing the blood supply to the alveoli, which results in necrosis of the alveolar structure, completely destroying the alveolar architecture. And here, in addition to that, there is also release of inflammatory markers such as complements, ICAM, and there's also release of cytokines which can further damage the alveolar structure. Histologically, we can see collection of this hyaline-like thick protein materials inside the alveoli. There is also edema of the alveolar walls. As time goes on, there are infiltrates and patchy necrosis of the alveolar architecture. And there's also conglomeration of these multiple alveolar cells with multiple nuclei, leading to what they call as multinucleated giant cells. Here's an expanded picture of accumulation of pulmonary edema. There's a hyaline membrane formation because of the inflammation created by the COVID-19 virus. And there's also damage involving the endothelial cells, which leads to micropulmonary thrombi. If you were to look at a chronic lung chest CT, you're going to see this meshwork of reticular formation, which is nothing but a reflection of a fibrosis of the lung tissue, replacing the normal alveolar structure. Unfortunately, these changes are permanent, and that leads to chronic debilitating symptoms these patients experience for months and maybe perhaps longer. So in a sense, long COVID lung syndrome is characterized by destruction of alveolar cells by the virus. There is destruction of the endothelial cells. The destruction of the endothelial cells leads to leakage of blood and also proteins, and there is also the intrinsic pathway of coagulation initiated, which leads to microthrombi inside these capillaries, leading to micropulmonary infarcts. There is cellular necrosis because of lack of oxygen supply, and eventually they are replaced by scar tissue. Dr. Mauro Gecka from King's College, London, looked at 41 patients, their lungs, heart, liver, kidneys, between February and April 2020. More than 90% of these patients had massive destruction of alveolar structure, replaced by scar tissue. I explained to you the pathogenesis of how the viruses get into the epithelial cells and the endothelial cells and destroy these cells. In the process, they also replicate, and these cells are replaced eventually by scar tissue. There is extensive blood clotting because of the intrinsic pathway of coagulation being activated due to endothelial damage. The lung cells are replaced by large cells with multiple nuclei, and this process is known as syncytia, and these are non-functional cells. The symptoms we talked about: persistent shortness of breath, fatigue, brain fog, weakness, and lack of energy. Here's a website where you can find more information about long COVID lung syndrome. WebMD reviewed some of these studies of long COVID lung syndrome, and Elaine Maxwell concluded that this may be a conglomeration of various different types of problems we see in patients with acute illness. Because of the acute illness, because these patients stay in the intensive care unit for several days, they could have post-critical care syndrome. And because they have gone through a serious virus infection, they also could have a post-viral fatigue syndrome. Of course, there's permanent damage, the blood vessels in the lungs, but also in the heart, in the kidneys, in the liver, and in the brain. And there are like a fleeting symptoms moving from one part of the body to the other, making the recovery very difficult, long, and cumbersome. Ladies and gentlemen, this is a quick overview of long COVID lung syndrome, which is characterized by massive destruction of the alveolar structure, endothelial structure in the capillaries, leading to thrombosis, reduced circulation, micronecrosis, leading to fibrotic changes in the lungs, which are permanent, leaving these patients with lingering long-term symptoms of shortness of breath, fatigue, weakness, lack of energy. Is there a treatment for this? The best treatment is to prevent these patients from getting these lung complications. So if we have a high risk group of patients who are likely to go into the intensive, who are having low oxygen levels, that's the time to use perhaps maybe a plasma transfusion or antibodies to neutralize these viruses and minimize the capillary and endothelial damage, with the hope that we can minimize the pulmonary destructive nature of this virus and improve their clinical and long-term prognosis. Ladies and gentlemen, you have been listening to COVID-19 World News. I am Dr. Nik Nikam, and before I go, I just want to invite you to take a look at my book, COVID-19 Pandemic, on Amazon.com and leave your comments. And this has been a COVID-19 World News presentation. Special focus on long COVID-19 lung syndrome. This is Dr. Nik Nikam from Houston, Texas. Thank you so much, and please do subscribe to our YouTube channel. We will see you next time.